Now we'll move on to the management of epilepsy. Okay, so we'll look at the various drugs and their mechanism of action and their side effects. Fine. So to simplify and help you understand the mechanism of action of various drugs, I've drawn a line diagram through which we will understand the various drugs used in epilepsy. So the first concept that we should understand is that any drug which is used in the management of epilepsy, should be inhibitory to the excitatory transmission, right? Because epilepsy is basically due to uncontrolled electrical activity in the brain. So any drug that we use should be inhibitory to the excitatory action, right? So it should inhibit the excitatory neurotransmitters. So it's as simple as that. What are the excitatory neurotransmitters? They are glutamate and the NMDA receptors, right? So they are glutamate which acts through the NMDA receptors. So the drugs which basically inhibit the excitatory action of these neurotransmitters are sodium and calcium channel blockers and potassium channel openers. Okay, so they are your sodium and calcium channel blockers and potassium channel openers. Or the other way is your drug can stimulate the inhibitory neurotransmitters to control the uncontrolled electrical activity, right? So they can stimulate the inhibitory neurotransmitters to subdue the uncontrolled electrical activity. So what are those? They act via stimulating which inhibitory neurotransmitters? GABA and glycine. Okay, so these drugs can cause stimulation of GABA and glycine, or they inhibit your NMDA receptors, or they inhibit your glutamate, right? So the way they inhibit your NMDA receptors or your glutamate is by sodium and calcium channel blocking or potassium channel opening. Okay, so this is a basic mechanism that you have to understand, and then we will understand each of the mechanisms much more in detail. So the basic mechanism is that any drug which we use in the management of epilepsy should inhibit the excitatory neurotransmission or increase the inhibitory neurotransmission. Okay, it's as clear as that. Fine. Now let us look at each of the drugs in detail. So this is your electrical synapse. So this diagram is showing your electrical synapse. So once the action potential arrives at your synapse, okay, once the action potential arrives at your synapse, what happens? It goes and stimulates your neurotransmitters which are stored in the vesicles. So it goes and stimulates the neurotransmitters which are present in the vesicles, and these neurotransmitters can either act on an excitatory synapse or an inhibitory synapse, right? So they can act on an excitatory synapse or an inhibitory synapse. Okay, fine. So this is your basic principle. Once the action potential comes, it stimulates the neurotransmitters which are released and act on an excitatory synapse or an inhibitory synapse. Okay, clear? Now, when it comes to the excitation action potential, we had told you that excitatory neurotransmitters are glutamate which acts via the NMDA receptors, and this is stimulated by sodium channel opening. So we give sodium channel blockers. As you can see here, the movement of sodium inside is going to cause an excitation action potential. So we give sodium channel blockers, which are the first group of drugs, and the sodium channel blockers which are given here, which is phenytoin, carbamazepine, rufinamide, oxcarbamazepine, then LACO is lacosamide, valproate and lamotrigine. Okay, so phenytoin, carbamazepine. So most of the drugs which you know, and especially the older antiepileptics like your phenytoin and valproate, act via sodium channel blockade, which inhibits your excitatory transmission to the synapse. So phenytoin, carbamazepine, lacosamide, lamotrigine, oxcarbamazepine, rufinamide and valproate. Okay, so we will talk about the side effects again. So this is about your sodium channel blockers. Also, you can see here that the movement of potassium outside is also going to facilitate your neurotransmission, right? So we give potassium channel openers which prevent your movement of potassium outward. So what is your potassium channel opener? The drug is your retigabine. Retigabine is the drug which is your potassium channel opener. Okay, fine. Also, we know that GABA is an inhibitory neurotransmitter, and GABA is broken down or metabolized into succinate semialdehyde. Okay, so GABA is an inhibitory neurotransmitter. GABA is metabolized into succinate semialdehyde. Now, do you want the GABA to be metabolized or do you want the GABA levels to go up? GABA is gamma aminobutyric acid. Okay, so this is an inhibitory neurotransmitter. You don't want it to be metabolized. So this GABA metabolism is inhibited by two drugs, which is your vigabatrin and valproate. So GABA is broken down to succinate semialdehyde and that has to be inhibited. We have to increase the levels of your inhibitory neurotransmitter, which is GABA. So that is brought about by vigabatrin and valproate. So you can see that valproate has dual action. It inhibits the breakdown of GABA and also it acts as a sodium channel blocker, thereby inhibiting your excitatory neurotransmitter, which is glutamine. Okay, fine. Now let us look at the drugs which act at the synapse level. Now we have looked at various drugs which act within the neuron. Now we are looking at the synapse. Okay, so once your neurotransmitters reach the synapse and they act on the excitatory synapse via various channels. Okay, they act on the excitatory synapse via various channels, which include your AMPA channel, your T-type calcium ion channels, and you have your potassium channel openers which act again here, right? So you need to inhibit your AMPA channels, you need to inhibit your T-type calcium ion channels, and you need to open up your potassium ion channels to inhibit your excitatory synapse, right? So you will have to inhibit your excitatory synapse. So we need drugs which are inhibitory to the excitatory channels. Okay, so what are your AMPA inhibitors? The newest drug which is available is your AMPA inhibitor, which is perampanel. Then we have potassium channel openers. We had already learnt about it. That is your retigabane. The drug is retigabane. Then you have your T-type calcium ion channel inhibitors, which include ethosuximide and valproate. So you can see the third mechanism of action of valproate is that it is not only a sodium channel blocker, but it is also a calcium channel blocker and it also inhibits your breakdown of GABA, right? So it's not only a sodium channel blocker, but also a calcium channel blocker and it inhibits the breakdown of GABA. Thereby, it inhibits the excitatory synapse and it stimulates the inhibitory synapse. Okay, fine. Also, we also have a inhibitory synapse, which is your other type of synapse. So you will give a drug which is going to increase the activity of an inhibitory synapse, right? And when the neurotransmitters come to your synapse and GABA, if it is released, then GABA is going to act via your chloride ion channel. So we can give drugs which increase your chloride ion channel activity, which includes benzodiazepines and barbiturates. So we give drugs which increase the chloride ion channel activity, which is your benzodiazepine and barbiturates. Okay, fine. Now this GABA is recycled. Right? It is recycled. So when it is being recycled, it is acted upon by GAT1. It is acted upon by GAT1 and this GAT1 inhibitor is your tiagabine. Because why? Again, you want to increase your GABA levels at the synapse, right? Because it's an inhibitory neurotransmitter. So you prevent its breakdown and the drug which you give is your tiagabine. Okay, which is your tiagabine. Alright, fine. Also we have gabapentin and pregabalin. Which also inhibit calcium ion channel, which is also involved in your breakdown of GABA. Okay, we are clear about this, right? Okay, then we have a very, very commonly used drug, which is your levetiracetam and brivaracetam. So what is the action of levetiracetam? Levetiracetam is a modulator. It is a modulator of SV2A. SV2A is a receptor which is present in the vesicles which enclose your neurotransmitter and it modulates the receptor such that it is going to inhibit your excitatory synapse. Okay, so it is going to inhibit your excitatory synapse by modulating your SV2A, which is a receptor present within the vesicles which carry your neurotransmitters. Okay, so that is the action of levetiracetam, right? So this is about the various drugs which are used in the management of epilepsy. We'll go through the mechanisms of action again and then we will come back to the same slide and look at the various side effects. Fine. So what are the drugs which act on your inhibitory synapse? So GABA is broken down into succinate semialdehyde, and this is inhibited by V-gabapentin and valproate. V-gabapentin and valproate. Okay, so GABA is converted into succinate semialdehyde, and this is inhibited by V-gabapentin and valproate. Then GABA is taken up by GAT1 for recycling, that is inhibited by piagabin. Then we increase your GABA activity on the chloride ion channel, increase your chloride ion channel opening, by thereby stimulating your inhibitory potential or inhibitory synapse, and this is brought about by benzodiazepine and barbiturates. Okay. Then drugs acting on your excitatory synapse, we have sodium channel blockers, which was your huge list of drugs like your phenytoin, your valproate, lamotrigine, carbamazepine, oxcarbazepine. Then potassium channel opener is retigabin. SV2A modulator is levetiracetam. SV2A is a receptor present on your vesicles which contain the neurotransmitters, and so SV2A modulator is levetiracetam. Right? So we have your NMDA or your AMPA receptor inhibitor, which is perampanel, and T-type calcium ion channel inhibitor, which is ethosuximide. Okay? So this is very clear. So you will not have to memorize, just have a picture memory of your synapse and your excitatory inhibitory synapse where what is acting. Now let us look at the side effects of the most common drugs. So phenytoin, right? So phenytoin is basically associated with, what is this image? This is gum hypertrophy. Okay, the other drug which is associated with gum hypertrophy is your cyclosporin, but that is not an antiepileptic. The antiepileptic associated with gum hypertrophy is your phenytoin. Apart from that, phenytoin causes something called as your purple glove syndrome, where there is ischemia of the hand and you can have a swollen purple looking hand, which is called as purple glove syndrome. Okay, then phenytoin can cause lymphadenopathy in the long run, which mimics a lymphoma because it can cause painless generalized lymphadenopathy. So this lymphoma or pseudo-lymphoma, which is caused by phenytoin, is characterized by painless generalized lymphadenopathy, and hence it is called as pseudo-lymphoma, lymphoma-like appearance pseudo-lymphoma. Phenytoin also has side effect on the cerebellum. So phenytoin toxicity can affect the cerebellum, resulting in ataxia, and chronic phenytoin use is associated with bone marrow suppression and anemia as well. So what are the side effects of phenytoin? Phenytoin causes gum hypertrophy, pseudo-lymphoma, then it causes purple glove syndrome and ataxia and anemia. Okay, then valproate. What are the side effects of valproate? It causes hyperinsulinism, androgenism, then it can cause tremors, it can cause hepatotoxicity, Parkinson-like disorder. Okay, it can cause tremors, hyperinsulinism, hyperandrogenism and hepatotoxicity. Apart from that, this can also cause blood dyscrasias because of bone marrow suppression. Fine? Okay. Now, what about retigabin? What about retigabin? Retigabin is a potassium channel opener, and retigabin basically causes abnormal perception of blue color within the retina, within the eye. So that is your retigabin. Then T-type calcium ion channels, we have ethosuximide. Ethosuximide, you would have heard, is the drug of choice for absence seizures. Ethosuximide is associated with a DLE-like rash. Okay, DLE-like rash, which is your discoid lupus erythematosus-like rash is seen with ethosuximide use. Okay, then we had this kainate receptor modulators. Kainate receptor modulators, the drug is topiramate, and topiramate we have seen in migraine as well. So topiramate is associated with increased risk of kidney stones. It is associated with increased ammonia levels and weight loss and glaucoma. It is associated with glaucoma, kidney stones, increased ammonia levels and weight loss. So that is your topiramate. So this is about the various side effects of various anti-epileptics. Okay. Another important side effect is a levetiracetam. Levetiracetam, as we will discuss in the next few slides, it is not the first line management of all epilepsies, though currently we are using it a lot. Okay, so we are using it in a lot of epilepsy syndromes, but that is not always the first line. Remember the most important side effect of levetiracetam. The most important side effect of levetiracetam is that this can cause suicidal tendencies and behavioral changes. It causes a lot of behavioral changes. Okay, that's when you will have to change levetiracetam to its analog, which is brevitacetam. Okay, so remember, this is about levetiracetam. Next, what is the important side effect of your drug? Carbamazepine. Carbamazepine causes SIADH and hence it can cause hyponatremia. The next drug is your lamotrigine. What is the side effect of lamotrigine? It can cause Stevens-Johnson syndrome and hemophagocytic lymphohistiocytosis or HLH, where you have macrophages eating up your RBCs in the bone marrow, causing severe pancytopenia. Okay, fine. So this is about the various drugs which are used in the management of epilepsy and their various side effects, right? Also, let us learn about two newer drugs which are used. The newer drugs used in the management of epilepsy, we have tonaberstat. Tonaberstat is a neuronal gap junction modifier which is used in the treatment of migraine with epilepsy, right? Tonaberstat is a neuronal gap junction modifier used in the management of migraine with epilepsy. Then we have ganoxolone, which is an allosteric modulator of GABA, and it can be used in focal seizures and infantile spasms. Okay, so the newer drugs are tonaberstat and ganoxolone. Clear? So this is about the various drugs and the mechanism of actions and the side effects of drugs used in epilepsy. Fine. Now let us move on to which drugs can be used in which type of epilepsy. Let us move on to which drugs can be used in which type of epilepsy. So like I told you, nowadays the most commonly used drug is your levetiracetam. Irrespective of what type of seizures it is, most of the physicians resort to levetiracetam. However, it is not always the first line drug. So, whenever you have a generalized onset tonic-clonic seizures, the first line drugs are lamotrigine and your good old valproate. Though valproate has so many side effects, it is still the first line drug, right? So, whenever you start lamotrigine, be aware that there is a risk of Stevens-Johnson syndrome and valproate toxicity you should be aware. Focal seizures, again it is lamotrigine. Then the other drugs which can be used is carbamazepine, oxcarbamazepine, and levetiracetam is a first line drug. Then typical absence seizures, it is valproate and your ethosuximide, valproate, ethosuximide and lamotrigine. Atypical absence seizures, myoclonic seizures, atonic seizures, again it is valproate, lamotrigine. Okay. So remember that valproate and lamotrigine are good old drugs, but they are still the first line drugs used in the management of epilepsy, right? So it's not always levetiracetam. Fine. Okay, the second line drugs you can go through. Now, let us move on to this understanding of what is status epilepticus. Okay, what is status epilepticus? So, status epilepticus is defined as seizure activity which lasts for more than 5 minutes. It's defined as seizure activity which lasts for more than 5 minutes, or if there are 2 seizures which are occurring without gain of consciousness in between. So, seizure activity which is lasting continuously for more than 5 minutes, or you have one seizure followed by another seizure, but in between the 2 seizures there has been no improvement in consciousness or no gain of consciousness between the 2 seizures. Even if it is within 5 minutes, this is your status epilepticus. Okay, fine. So, status epilepticus can be classified as convulsive status epilepticus and non-convulsive. Okay, so status epilepticus can be classified as convulsive status epilepticus and non-convulsive. Convulsive is where your seizure activity is visible. So, there is visible tonic-clonic movements or visible focal seizures. Then, non-convulsive is where the seizure activity is not visible, right? But the electrical activity in the brain is still going on, but outside you do not see any evidence of seizures. That is your non-convulsive status epilepticus, and this is diagnosed only by means of an EEG. So, they will just present with altered sensorium, they might be not responsive to commands, and only when you do an EEG you will see the evidence of non-convulsive status epilepticus. Now, status epilepticus, based on how long it has been there, it can be classified as early, refractory and super refractory. Early status epilepticus is up to 10 minutes. Refractory status epilepticus is when your status epilepticus continues on anti-epileptic drugs and benzodiazepine. The first line drugs are benzodiazepine and second line drugs are AED. So despite this, if the status epilepticus is continuing, it is refractory. So 30 minutes is early refractory. If it is more than 48 hours, you still have seizure activity, it is late refractory. Super refractory status epilepticus is basically your status epilepticus continuing beyond 24 hours after starting even anesthetic drugs. You have started anesthetic drugs and beyond 24 hours of starting anesthetic drugs also, you are seeing evidence of epilepsy. That is your super refractory status epilepticus. So when the patient is intubated, ventilated and he is on anesthetic, obviously you are not going to see seizure activity because he is under muscle relaxants or muscle paralysis, right? So how will you identify here? You will identify EEG evidence. You will see for EEG evidence of status epilepticus. Where is the super refractory status seen? Super refractory status is seen in your NMDA receptor encephalitis. It is seen in NMDA receptor encephalitis. Okay. And what is the characteristic EEG finding that you find? It is called as extreme delta. It is called as extreme delta brush. Extreme delta brush pattern is seen in your NMDA receptor encephalitis, which is one of the most common causes of super refractory status epilepticus. Okay. Now let us move on to the management of status epilepticus. So the first line management, remember, it is a IV benzodiazepine. The first line management is a IV benzodiazepine. You give lorazepam or midazolam, which is 0.1 mg per kg or 0.2 mg per kg, or clonazepam can also be given. But the most common is your lorazepam. Okay, fine. So lorazepam is a benzodiazepine drug. Then IV anti-seizure. What is the, along with your lorazepam, you may have to give an anti-seizure medication, which can be a phenytoin, valproate or levetiracetam, which is given at a dose of 20 to 30 mg per kg, right? So you can give benzodiazepines, which is your lorazepam, or next you move on to anti-seizure medications, which include phenytoin, valproate or levetiracetam, right? If there is no improvement with this in your early seizure status epilepticus 5 to 30 minutes, then you will have to move into your established early refractory status epilepticus. Right? So depending on what type of seizure it is, you may have to change the drugs a little bit. For example, if it's a focal, myoclonic or absence, then you may have to think of pregabalin, topiramate and so on. Okay? But otherwise, you can continue with your IV midazolam, and you may require anesthetic drugs like propofol. Okay? So, if the patient is not responding to first line benzodiazepine, second line anti-seizure drugs, then you may have to use anesthetic agents. Okay, you may have to use anesthetic agents like propofol, and THP is your thiopentone. Okay, so you will have to intubate the patient. And start them on anesthetic agents. Late refractory status epilepticus is when they have been on anesthetic agents for more than 48 hours, there is still seizure activity that is going on. Then you will consider other anesthetics like isoflurane, desflurane, other medications which are not really having a complete benefit, but they can be given under trial like lignocaine, verapamil and immunomodulatory therapy. Okay. This group of other approaches that we are seeing, like an ECT or a surgery or a transcranial magnetic stimulation, these cannot be done during your status epilepticus. Only after they come out of it, they can be taken for these kind of treatments. Okay. So this is about the management of status epilepticus. Okay. You should be clear about the definitions, and you should understand the first line is benzodiazepine, second line is anti-seizure drugs, third line is anesthetics. Clear? Fine. So with this, we have come to the end of our chapter on epilepsy. We have learned about the etiologies, how to approach a seizure. We have learned how to differentiate the different types of seizures, the different types of EEG patterns. We have understood what are the various types of seizure syndromes, and we have understood the management, side effects, drugs and status. Thank you.